Good morning, everyone. Good morning, and welcome to the 2021 Illinois Reentry Conference. We are super excited to have each of you with us today. The theme of today's conference is Advancing Criminal Health and Social Justice Amidst Two Pandemics, COVID-19 and Racism. My name is Rashonda Johnson, and I am a manager at Public Health Institute of Metropolitan Chicago. For the past 4 years, I have been fortunate to manage our Community Reentry Project, which is a multi-stakeholder initiative that coordinates reentry efforts in Illinois. Today, I have the pleasure of serving as your conference moderator, and I can say that you are in for a great treat of a day. Before you hear from our presenters, I would like to walk you through a few conference items that can be accessed on today's conference platform. If you look at the top of your screen, you will see several tabs. You will have main stage and chat, which is where you can access all of today's live shows in our main section. You will have your conference agenda, where you can locate where you should be throughout the day. You will have your breakout rooms, which you will go to in both the morning and afternoon. You will have your speaker bios, where you can see all of the wonderful backgrounds of our presenters for today. And then you will see a partner tab, where we have listed some of our partners in making this event. We hope that you find the conference platform easy to navigate and accessible for all of your conference needs. This year's conference will focus on helping each of you rediscover, reimagine, and rebuild best practices in criminal health and social justice amidst two pandemics, racism and COVID-19. We know that this last year has been like no other, and in this new world, many of us are learning to pivot our services, our outlook, and even our very lives. Our hope is that you take from today a fresh perspective, tips, and tools that will help you now and in the times to come. Before we have our first plenary session, I would like to welcome Karen A. Reitan, who is PHIMC's President and Chief Executive Officer. Karen will give us welcoming remarks, and please at this time help me welcome her to the stage.
Great, thank you, Rashonda. Good morning. Thanks, Rashonda, for kicking us off and for all the work you did creating this amazing agenda. I also need to thank Cynthia Lee, who collaborates with Rashonda on our reentry work, and the other PHIMC staff who are helping out today. On behalf of the board and staff of PHIMC, I'm so delighted to welcome more than 250 of you to today's meeting. How I wish we could be all together in the same room, feeling the energy of so many people committed to justice for returning citizens, their families, and their communities. PHIMC is proud to have been a partner in the Reentry Project since its inception in 1999. Though this project has changed a lot over the many years, its core function of supporting people living with and at risk for HIV as they transition from incarceration to community is as necessary today as it has ever been. Over the years, our focus has expanded as our appreciation for and our understanding of the broad range of supports that returning citizens not only need, but also deserve. As Rashonda said, this last year has been a doozy. There are not enough adjectives to adequately describe the turbulence that we experienced in 2020. The dual pandemics of COVID-19 and racism, videos of the murder of George Floyd broadcast across the internet, the demonization of peaceful protesters and Black Lives Matter, the murder of Breonna Taylor while she lay sleeping in her bed, and the denial of systematized and institutionalized oppression and how it shapes the experiences that people of color, particularly African Americans, have while simply trying to live their lives in a racist nation. The word reckoning is used so much these days, I looked it up, and on Merriam-Webster's website, they give a sample sentence to describe reckoning, and it is, when the day of reckoning comes, we will have to face some unpleasant truths. Truer words could not be said to white Americans as we are reaping what we have sown into the fabric of our nation for more than 400 years. PHIMC supports the statement of the American Public Health Association and our other local and national partners that racism is a public health crisis. We knew that long before we said it. and we know that people who are oppressed simply cannot live healthy lives. Today's conference puts the issue of justice, criminal justice, health justice, and social justice front and center where it belongs. The discussions will be led by experts who have lived and worked in these issues for many years. As you learn from them, they will also learn from you, from your expertise gained by living and working in these issues for many years. Ultimately, our hope is that when the day is done, all of us will be renewed, filled with new knowledge, strategies, and enthusiasm for the work we will do tomorrow. Thank you so much for choosing to spend your day with us. Thank you so much for the work that you do. Thank you so much for your passion and commitment to justice and the future that it promises. I hope you enjoy every single minute of this day.
Thank you, Karen, so much for that amazing start to our day. It was a powerful statement. We really appreciate you joining in to start our day with that remark. At this time, before we proceed with the day, we want each of you to know that PHIMC is committed to creating a safe space for all attendees today, and this is super important. These are some challenging topics that we are getting ready to address today around COVID-19 and racism, but we want everyone to know that this is a safe space where you can be fully self-expressed without fear of being made to feel uncomfortable, unwelcome, or challenged on account of race and ethnicity, sexual orientation, gender identity or expression, cultural background, and or your experiences. Let us do our best to make sure everyone's voices and experiences are heard, and we ask that you remain open to learning something new that you can take back to your spheres of influence. Thank you for joining us and for showing your dedication to this very important work. So at this time, we will have our first morning plenary. I would like to invite Naomi Sugar, who is PHIMC's Vice President of Programs, to introduce our session and our presenters. At this time, help me welcome Naomi Sugar.
Hello, everyone. Thank you, Rashonda, for that wonderful introduction. I'm Naomi Sugar. I use she, her pronouns, and I'm Vice President of Programs here at PHIMC. I have the distinct honor and privilege to guide this morning's discussion with Dr. Stephen Shrantz and Dr. Robert Fullilove. Our opening plenary is titled COVID-19 Vaccines, Understanding and Misunderstanding Their Importance. After your participation in today's session, our hope is that you'll have an increased understanding about the current vaccines available for the prevention of COVID-19, an understanding and appreciation for the misconceptions that are presently leading many people towards vaccine hesitancy, and a recognition of the barriers to COVID-19 vaccination and prevention in certain populations, including persons with criminal justice involvement. We have two phenomenal speakers to guide us this morning. First, Dr. Shrantz. Dr. Shrantz is a physician and assistant professor in infectious diseases and global health at the University of Chicago Medicine, with interests in HIV treatment and prevention, clinical delivery of care to both adults and children, and more recently, treatment and prevention of COVID-19. He's currently active in several clinical trials involving COVID-19 treatment and vaccines, and educational programs that update community physicians and nursing home administrators on the current state-of-the-art care and prevention of COVID-19. Dr. Shrantz serves on the Medical Advisory Board for Illinois District 65 Schools to Safely Reopen, and he is also the medical director of the Mother and Child Alliance, which is dedicated to the elimination of mother-to-child transmission of HIV in Illinois. Dr. Fullilove, our second speaker, is the Associate Dean for Community and Minority Affairs, Professor of Clinical Sociomedical Sciences at Columbia University Mailman School of Public Health, and the co-director of the city's research group. Dr. Fullilove has authored numerous articles in the area of minority health and served on the Board of Health Promotion and Disease Prevention at the Institute of Medicine at the National Academy of Sciences. Since 1996, he has served on 5 IOM study committees that have produced reports on a variety of topics, including substance use and addiction, HIV/AIDS, and tuberculosis. Dr. Fullilove sits on numerous committees, was designated a National Associate of the National Academies of Science, was appointed to the Advisory Committee on HIV and STI Prevention at the CDC, And in July 2000, he became the committee's co-chair. For the past decade, Dr. Fullilove has been teaching public health courses in 6 New York State prisons that are part of the Bard College Prison Initiative and serves as the senior advisor to BPI's public health program. And on a personal note, many moons ago when I was in graduate school, Dr. Fullilove was one of our esteemed professors. So it is really an honor and an absolute full circle moment for me to be sharing this virtual podium with him. So without further ado, I welcome Dr. Shrantz and Dr. Fullilove. At the end of both of their talks, I will return to facilitate a Q&A session. Please keep in mind that because we are limited with time, we can only take about 2 to 3 questions. I turn the floor over to both of you. Thank you for being here.
Dr. Shrantz, if I'm not mistaken, you go first or do I go first? I don't know that. Had we established the priority here?
Dr. Shrantz will start us off.
Very good. Thanks so much. It's nice to meet you all virtually. Dr. Fullilove, not had a chance to meet you in person, so I'm glad to get this chance to meet you through electronic media. All right. Thanks, everybody, for joining us today. This is an exciting topic, and I'm so pleased that you invited me to speak today. This is my title slide. I try to make it as colorful as possible. I'm always looking for new pictures of coronavirus, so this is the last one I've found. But today we're going to be talking about the understanding and, unfortunately, some of the misunderstandings regarding the COVID-19 vaccines. And I'm going to advance my slides as soon as I reconnect to the internet here with my phone. Pardon the delay. Let's see if this works. There we go. Great. So I don't have any disclosures from a financial conflict point of view. I do have to say, though, that things change very quickly in this field. There are at least 3 slides that I would have enjoyed presenting today that just came up in the last week. So things move fast, and so if there's something that I present that's already out of date, I apologize. So the outline for today, I thought we would talk about a review of the current COVID-19 vaccines. And we can talk about current misconceptions regarding the vaccines. Also, strategies for discussing the vaccine with vaccine-hesitant individuals. And then I'm lucky enough to be able to present to you some data from recent surveys regarding COVID-19 and persons with criminal justice involvement. This is data that was shared with me from colleagues here at the university that has yet to be published. So I'm hoping that will spur some interesting discussion as you move through your day. I always tend to start these discussions with just a general epi slide looking at where we are with the epidemic. I've been giving talks on COVID-19 for a year now, every other week, doing educational sessions with primary care physicians here in Chicago. And I always start the talk with where we are. The good news is we're in a much better place today than we were just a few months ago. I think everybody on this conference recognizes that. And I'm also happy that the New York Times has been very good at publishing very clean and colorful maps and graphs that are easy to copy and paste in the slides. So here you can see the trend over the last month has been exactly what we'd like to see in the right direction, with the slope trending downward. And we are back to where we were really during the summer months in the United States. Following that are the number of deaths due to COVID-19, as well as the number of hospitalizations due to COVID-19. This heat map on the right here of the United States shows, again, the trends are all in the right direction. If I had shown you a heat map just a month ago, this would have been a much brighter red, especially in areas around Southwest and California. And if you go further back into the winter, the upper Midwest was also an area of great concern in terms of COVID-19 spread. So why are the cases dropping recently? This is not a simple question, and there's no simple answers. This will be one of those things I think we look back over the years and then look back and try to understand. But what we're seeing is, the possibility of seasonality effect. There's also the possible chance that we're just seeing the herd immunity finally reaching a state where we're going to see reduced transmissions. Remember, herd immunity is a a number that's a percentage of the population that's either been vaccinated or infected. So it could be that we're seeing that. Could also be that during the winter months, people have actually been able to adhere to some of their mitigation efforts and that there's been some behavior change. There's always the possibility that these new variants, remember, everybody's concerned about several of the variants we'll discuss this morning in terms of increasing transmissibility and increasing the possibility of more severe disease. But there's also some variants that might be spreading that are less virulent, and that could also be contributing. And thankfully, we now have several vaccines that could be also contributing to this. It's also important to note on this graph here to the left that this is a pandemic, and what we're seeing across the world is a decline in deaths and a decline in cases. So all in all, this is a good sign. But again, this is 2 weeks ago data. I can tell you that the trend has continued in the right direction over the last 2 weeks. So the concentration for the rest of the talk today will be on the vaccines. And the traditional vaccine development is usually very many years. We're talking usually 5 to 10 years. And one of the problems that people have noted in terms of hesitancy regarding the vaccine is how quickly these vaccines came to market. And what we're seeing here is a rapid advance of vaccine technology as well as initiatives to produce a vaccine as quickly as possible. And what we saw with Operation Warp Speed and on a global scale, COVAX, to bring these vaccines to the people who need them greatly as quickly as possible without sacrificing the safety. And so this chart that was taken from the New England Journal kind of shows how this has happened in terms of condensing the time that's required. I also want to say that this chart really doesn't do it justice because really the development of these vaccines goes back decades. The first technologies for mRNA vaccines and recombinant DNA vaccines goes back into the 90s or even earlier in some cases to develop these vaccines. And what's important to recognize is these technologies were ready to go on the shelf, just waiting for the right time to be deployed. So that's another reason why this was so quick to get to a vaccine. And we're so lucky to have tools now to fight this pandemic today. So as I was mentioning, also the researchers use existing networks to conduct these vaccine trials. Many of these were networks that were established for testing HIV vaccines. And unfortunately, our HIV vaccines have not been as productive as our COVID-19 vaccines. However, that network was established and allowed us to quickly use these networks to get the research out for the clinical trials that are needed to show the safety and efficacy of the current COVID-19 vaccines. The other thing that happened is manufacturing began while clinical trials were still underway. This was the crux of the Operation Warp Speed, that we were able to fund these companies to start development and manufacturing while the trials were ongoing. Most companies aren't going to be willing to make that sort of gamble. We're talking usually billions of dollars, and so without the backing of the U.S. government and other governments, made that very possible to move forward quickly. The other nice thing is the current technology is the mRNA vaccines, and now the DNA vaccine from Johnson & Johnson are faster to produce than traditional vaccines. We don't need to incubate chicken eggs the way we would for flu vaccines, for example. This can occur much more quickly. And the FDA and the CDC have been prioritizing review and authorization. So there's been just an increased effort to make sure that this goes as smoothly as possible, as quickly as possible. So let's talk real quick about the mRNA vaccines. This is a slide designed to bring everybody up to speed on how these work. It's been really interesting to watch how the media and social media have talked about technology around vaccines. I think the public has been more interested in the biology of this disease than any disease I can remember in recent past. And so people are now learning about mRNA and DNA and trying to remember what they learned in their high school biology class and bring it back to life. So simply, mRNA is the precursor code to DNA it's a step from DNA to the making of the protein. So it kind of skips the DNA and is just the messenger that allows the cell to know what type of protein to make. And what we've done is developed a lipid nanoparticle that can protect that mRNA and bring it to the cell and allow the cell to then process that mRNA to develop the spike protein, which is the fundamental part of the coronavirus that it uses to infect our cells. And so by presenting this spike protein to the system, the body is then able to make antibodies and other cells that recognize this protein as foreign, and that then can then neutralize it so that it doesn't have the chance to infect cells. I've heard many different analogies for this vaccine. The one I like the best, well, there are two. One is, imagine this is a M&M, and the chocolate inside is the mRNA, and that candy coating is the outside. And remember, M&Ms don't melt in your hands, they melt in your mouth, right? I probably got that backward. They melt in your mouth, not in your hands. But regardless, that's the concept that was used here. So if you just were to inject the mRNA without that lipid nanoparticle, it would dissolve immediately and not get to where it needs to go. So the real technology change over the last several years is developing this lipid nanoparticle to protect the mRNA. Next. There we go. And because we are in the middle of a pandemic, we were able to deploy these vaccines and do so in a way that we could study them very quickly. With the amount of coronavirus that was circulating, we were able to meet the endpoints of these trials much faster than many of our other vaccines that have been tested in the past because of just the sheer volume of virus that's circulating in the world today. What I have here on this slide are our summaries of the mRNA vaccines that were published in the New England Journal. The one on the left here is the data from the Moderna study, and the one here on the right is from the article describing the Pfizer vaccine. I think what's important to recognize are these two graphs that summarize the efficacy of these vaccines. And I think it's very clear from looking at them, they're very similar graphs. And it's also very easy to see that the lines diverge quite severely. And that goes to how effective these vaccines are during these trials, with a 95% efficacy rate or 94.5% efficacy rate described in both of these studies. The other nice thing to recognize is that the safety of these vaccines are both comparable with very few systemic adverse events and an occasional injection site adverse event after the first or second dose. There's been many discussions about some of the adverse events that occur with these mRNA vaccines that have more to do with reactogenicity of the vaccine. Reactogenicity is a term that we use to talk about the type of reactions people have to the vaccine. So these would be things such as fever, muscle aches, headaches. These have all been well described, and everybody at this point has probably heard a story of somebody that had not such a great day after their first or second dose of these vaccines. However, the important thing about these vaccines is recognizing that severe disease was completely eradicated by this vaccine, as was hospitalizations and death. So, and we'll go back to this and talk about why that's an important thing to emphasize as we talk about new vaccines as they come up. So this week we've all been concentrating on the newest member of our tool chest, which is the Johnson & Johnson or Janssen vaccine. And this vaccine adds some important caveats. It's a single-dose vaccine, and it doesn't require the same freezing techniques or severe refrigeration techniques that the mRNA vaccine has. And this is exciting because it will be easier to use. It just received emergency use authorization earlier this week. And the earlier studies showed that this was 72% effective at protecting against moderate to severe illness in the United States, and compare that to 66% effective in Latin America and 57% effective in South Africa. It's important to recognize that this study was done on a global scale in different areas, because now we're recognizing the importance of the variants of the virus and how these might be affecting the vaccines. It's also important to recognize that all these vaccine studies were done a little bit differently and in different parts of the world. So comparing a study to a study is kind of like comparing apples and oranges. And we'll talk about that as we go through these slides, because this is coming up frequently now. It was 85% effective overall at preventing severe disease, and again, 100% effective at preventing death. All the vaccines that we've tested so far have been 100% at preventing death and severe illness. So that's an important thing to recognize, is that even some of the newer vaccines that I'll talk about in a second were important about preventing hospitalizations. A couple things about the Johnson & Johnson vaccine you may not know is that there is another study that's being started just now that's going to follow up the first study, which was the one dose, to see if a second dose makes any difference, to see if we get more immunity with a second dose. So we'll be studying that in the coming months. And it's also important to recognize that the U.S. government had purchased 1 million doses of this vaccine, and hopefully they will be delivered by the end of June. It's also mentioned just this week that the United States government helped to broker a deal between two companies, Merck and Johnson & Johnson, to also increase the production of this vaccine. So this vaccine is different than the mRNA vaccines. It uses an adenovirus vector, which is basically a cold virus. And this is a particular type of cold virus that doesn't cause any severe disease in humans. This has been a platform that's been well studied in other vaccines, including the Ebola vaccine in Africa that was recently used within the last 5 to 7 years. And it has a very good safety record. And essentially what is done in this vaccine is the coronavirus spike gene is included in the nucleic acid material of the virus that then is able to insert that into our cells and allow our bodies to make the coronavirus spike peptide. Very similar to the mRNA vaccines, it's just a different delivery mechanism. Oh, I apologize. I'm told I only have 5 minutes, so I'm going to be quick. So we've talked about the Johnson. So this vaccine is as efficacious as the Janssen vaccine. As the mRNA vaccines. The Novovax vaccine is also coming out and will be quite effective, showing 90% effectiveness in preventing the vaccine. And the hope is that this might be part of our tool chest in April or May. And we're seeing more and more vaccines being deployed. This is important to see. So we have now 1.9 million doses per day being delivered in the United States. So I want to move into just some reported concerns about the vaccine and the idea of vaccine hesitancy. So what we see is with vaccine hesitancy is there's this continuum of high demand to no demand. And you either are accepting all of it, and then over this continuum, people are going to be accepting or delaying or refusing but not sure. So this is a nice diagram to consider when you're thinking about vaccine hesitancy. The other thing to consider is these 3 C's, the complacency, confidence, and convenience of the vaccine. So these are the 3 things that we can consider targeting as we want to combat vaccine hesitancy. Some of the reported concerns about the vaccine, and many of you have heard some of these concerns, is that the feelings of that communities of color are being targeted or being used as guinea pigs. Unfortunately, the media coverage has amplified this. and many of these communities are wary of the vaccine. There have been social media posts that have really somewhat without, there's I want to use the word crazy, but it's really challenging because there are so many different conspiracy theories regarding this that are circulating on social media posts, including the possibility of microchips being in the vaccine, that it can cause infertility, what have you. There's also the short-term side effects that are being concerned about. Long-term side effects, since there was a short study period on these, or relatively short study period. There's also the concern about language barriers and whether or not things are being lost in translation. And I don't want to underestimate the historical injustice that's occurred in this country against peoples of color, and how this has changed people's perception of this march towards getting people towards accepting and using a vaccine. One of my colleagues, Dr. Schneider, was able to have some qualitative research trying to understand some of this vaccine misinformation. Thoughts that the vaccine has fetuses or strains of other viruses. This is something that has actually been brought up frequently in the Roman Catholic Church, and concerns about the virus in terms of using aborted fetuses. However, the Pope recently came out and said that he's comfortable using the vaccine, and that's all the vaccines. There's also thoughts out there that people can contract COVID-19 by getting the vaccine. This is a common misconception about many vaccines, but it's important to emphasize that this is not a live virus vaccine. There is only the mRNA of the vaccine, and therefore it cannot cause COVID-19. Thoughts about the vaccine being developed too quickly just to make money. And so this is a common misconception that can occur amongst many of our patients, friends, and family. So as we think about our vaccine communication tactics, it's important to understand where people are in terms of their accepting of the vaccine. Are they a definitely yes? Then we need to ensure accessibility and ease. If there are probably yes, then we need to do that, as well as think about creating triggers to prompt a I need to do this now mentality, trying to move people away from the complacency that can occur. If they're somebody who's a probably no, we need to connect them to trusted vaccine or medical advocates. Oftentimes the word of mouth from somebody that they know and trust is a much more effective tool than just using an educational platform. And if somebody's a definite no, it's very important to avoid judgment, patronization, and to try to partner with opinion leaders in their community to try to help them to further understand this vaccine and why it can be useful for them and all of us. So I also do some educational work with nursing homes, and these are some of the promoting vaccines amongst the staff in nursing homes that people came up with. So to hold focus groups to better understand vaccine hesitancy, to have one-on-one conversations with staff members who have questions, to designate vaccine champions in each department, and essentially have staff that were vaccinated be honest and open about their experiences to try to convince their friends and colleagues that the vaccine is a good idea and will help protect all of us. As we talk to our friends, colleagues, patients, and clients about the vaccine, it's important to kind of think about how we are talking to them and using motivational interviewing techniques. A acronym's been developed for this called OARS, meaning that we start with open-ended questions. We affirm the person's efforts, strengths, resources, successes. We have some reflective listening where we reflect back what you've heard, allow people to hear their own thoughts and feelings, and then we summarize with those actions. The last part is important. This is the plus, and this is where we can provide our own information and advice, but really it's important to get permission before you do that. Nobody wants to feel that they're being preached to without their permission. So this is an important technique that we can use And so here are some examples. So again, open-ended questions. How are you feeling about the vaccine? What concerns do you have? And then following that with an affirmative statement, I see you really care about this. You've really done your homework on this. Reflections, sounds like you're worried about, these sort of problems. This is where you reflect back what you've heard. So this is, again, that receptive technique. And then using some summary statements that bring all these things together. So you mentioned several things you could do to find out more. And then again, that plus, if you can offer your own advice, your own experiences with the vaccine, if you have permission to do so. When I got the vaccine, I did have a fever that night before, but I took some ibuprofen and it got better, and now I feel great. And I'm glad that I'm helping society get through this and that we can eventually get to some normalcy in our society. Okay, I apologize. I had a misunderstanding regarding the amount of time that my lecture was given, so I had overdeveloped slides. So I wanted to quickly share with you some of the survey data that was shared with me from my colleagues here at University of Chicago regarding people in the criminal justice involvement and their opinions regarding the COVID-19 vaccine. So the hesitation to seek medical care actually is one of the things that didn't differ for people who have criminal justice experience. So that's a good sign that people who are have been in the criminal justice system are willing to get care for COVID-19. However, And the other good thing is that many people who have vaccine plans does not differ that significantly from the overall whole sample. So that's a good thing. Some protective actions, though, differ by people who have criminal justice experience. We notice that people who have criminal justice history many times take no steps to decrease their exposure or likelihood of contracting COVID-19 and are less likely to wash or sanitize hands and potentially are avoiding or less likely to avoid in-person contact based on their concerns for COVID-19 exposure. One of the interesting reasons, though, when you ask people about their reasons to get vaccinated or not to get vaccinated, for people who have interactions with the criminal justice system, you can see most people say, I want to get vaccinated to protect my family or myself. And that's all. It's true across the board. However, the top reason to not get vaccinated is actually different for people with criminal justice involvement, where they're more concerned about politicians that might promote the vaccine to win votes, even if it's not fully tested or safe. So it's interesting that that was the number one concern among people with criminal justice involvement compared to concern about side effects, for example. And that's where we see all participants and people with opioid use disorder. So here's where the key difference is. So respondents that had a personal history of the criminal justice system were more likely to get tested for COVID and have a positive COVID test and have somebody in their household who had a COVID death, unfortunately. They're also more likely to not take any steps in response to COVID-19. And they're also more likely to have issues paying rent or mortgage due to COVID-19. They're also less likely to avoid in-person contact with friends or family due to COVID-19, and they are less likely to wash or sanitize hands. So these are important caveats to recognize as we think about educating our patients, colleagues, friends about COVID-19 and trying to get uptake of the vaccine that will hopefully continue and will interrupt the transmission of COVID-19 in our society and be able to return us to some semblance of normalcy. So I'll stop there. Thank you so much for inviting me to speak today, and I apologize for going over my time.
So, without further ado, glad to see you all. I've got, if I'm not mistaken, about 15 minutes to give what would have been a 30-minute lecture. So I really understand the time pressure here. And I want to take a slightly different approach because my interest in talking to you about what it is we're all about in this conference has everything to do with the public health argument that says that maybe the most important thing about where we are here is not so much the fact that there's obvious and very important ethical considerations here that mandate are making sure that vaccines are available to incarcerated persons. Because the Constitution basically protects the right of people who are incarcerated so that getting access to health care is part of what keeps them from being subjected to cruel and unusual treatment. We often make the argument that we should be doing this simply because our ethics demand it of us. That's true. Our ethics do demand that of us. But maybe the more important thing to understand is the public health argument, which is as much about what happens to the general population in the midst of a pandemic, when, as epidemiologists tell us we should never do, we leave a large portion of the population untreated, and as a consequence, create a reservoir of infection from which variants and other forms of mutated virus can develop. That's certainly the situation that we're in now. And part of what I want to argue here is that we are in a system that has it clear. The most important thing about COVID-19 isn't just who is infected, who's impacted, it's where you find it. I want to make it clear that the geography of this pandemic is critically important. We live in a segregated society. Segregation creates a variety of things, but in a pandemic, it also creates an interesting and sometimes deadly pattern of exposure to the pathogen. We're dealing with that now, and we're dealing with it in a way that has us understand that if you're going to be clear about what drives COVID-19 in incarcerated settings, you have to understand how intimately these settings are connected to the communities from which so many incarcerated persons hail. Prisons may be far away physically, but the circulation back and forth, the fact that in many communities of color, the prison or the jail is an institution that is as much a part of community life as anything else, owes much of its origins to segregation. There's a quote from the good Professor Williams at Harvard. Considerable evidence suggests that because of segregation, the residential conditions under which African Americans, American Indians, and an increasing proportion of Latinos live are distinct from those of the rest of the population. It's important to understand that what we're dealing with is the fact that segregation is so much a part of American life that we often ignore how important it is for our understanding of something as simple as public health. Part of what occurs with presentations like this is that we have to move our slides using a telephone, which isn't always connected to the internet. This is a picture of American society based on the 2010 census. It makes it clear that whatever our notions are about the U.S. being a melting pot, we're much more a mixed salad. The basic message in these slides is that whites live in neighborhoods with low minority representation. Blacks and Hispanics live in neighborhoods with high minority representation and relatively few white neighbors. Asians, with a much smaller portion in most metropolitan areas, nevertheless live in neighborhoods where they are disproportionately represented. So what does that have to do with COVID-19? The answer is everything. Housing segregation is basically what has created the patterns of morbidity and mortality that are part of the everyday headlines that try to measure how this pandemic is progressing. Okay, very good. The system of advancing these slides on my phone is really crude. It's really important, if I can get back to this previous slide, and it won't seem to move. Tell you what, let me just be clear that part of what we're looking at is this. From 1934 on, we have as a nation failed to invest appropriately in urban development in the United States. What we've done is much more a function of what was done in the 1930s with the creation of this and some 240 other slides. that tried to advise banks on where to make investments at the point when the Depression was making it hard for cities to survive, and banks were trying to do their best to figure out how to make investments that would bring the economy of America's urban centers back to life. Auditors were sent from the Homeowners Loan Corporation in Washington to more than 200 cities in the United States, where they drew up maps like this. And those of you who know these maps know that what you're looking at is a pattern of segregation. The red-lined areas were the places that had dilapidated housing, a large influx of immigrants, specifically from Eastern Europe, and a substantial number of people of color, but most especially Blacks. Neighborhoods that were dominated by that kind of population and poor housing, and neighborhoods near them were all red-lined. And as a consequence, we're looking at a pattern of a lack of investment in American cities that has haunted us with this particular pandemic. We're looking not just at what happened in the 1930s, we're also looking at what has happened subsequently, when we have discovered that many of the areas in the United States that were redlined are to this day still rigidly segregated. In fact, it is probably the case that what occurred in too many areas with federal investment in federal housing was that these formerly redlined areas then became areas that were much more likely to be Black and impoverished than was the case in the 1930s. So we're looking at a pattern that does not change. It is a pattern that over time, as the slide suggests, has seen that redlined neighborhoods have, with each successive decade, gotten more and more Black, more and more people by folk of color, and more likely to be mired in poverty. Trying to get the slide to move. This is the enduring legacy of redlining. Neighborhoods that were redlined in the 1930s are overwhelmingly segregated in the year 2021. Because public education is financed by property taxes, poor neighborhoods have poor schools and low educational achievement. It means that redlining also impacts home ownership, which is the source of wealth for so many Americans. But these typically are white Americans and not Black Americans. It's one of the most enduring, if you will, patterns of segregation in the United States, that where you live dictates how well you're educated. How well you're educated will probably determine what kind of job you will have later on, and what kind of job you will have and what race you are will determine where you're likely to live. And increasingly in 2021, where you're likely to live is going to be associated with life in a community that is heavily hit by COVID-19. The comorbid conditions that are associated with COVID-19, hospitalizations and mortality, are heavily concentrated in historically redlined, segregated communities. If you were to look at a map of New York City, where I'm speaking to you at the moment, you would discover that life expectancy in this city can vary by as much as 11 years, with the highest life expectancies in the neighborhoods that have the highest numbers of people who are upper middle class or downright rich. And the lowest life expectancies are basically in poor communities of color, where segregation has had a great deal to do with access to healthcare and the likelihood that people would be living with a set of conditions that make obesity, cardiovascular disease, diabetes, and other chronic conditions that are so much a part of the mortality of COVID-19 highly prevalent. Where you live has a great deal to do with your health. And if your health is dominated by something like hypertension, which affects maybe 60% of all African American men, that hypertension is a contributing factor to hospitalization and mortality from COVID-19 means that this ongoing, enduring pattern has something that has affected us hugely and is killing us when we start to look at the impact that COVID-19 is having. But are we also clear that redline neighborhoods have more crime and more police? Isn't that the case that many of the colleagues that we have who are doing time behind bars were in neighborhoods that were highlighted as hot areas of crime? That's where police are deployed, and where there are police doing the surveilling of what goes on, the likelihood that you'd have a stop and frisk scenario, which will result in large numbers of people being stopped, thrown into jail, and perhaps winding up in prison, once again, has a great deal to do with where you live. redlined areas are home to a substantial number of incarcerated persons. Here's how I understand it from the state of New York and the city of New York. Eddie Ellis, the late Eddie Ellis, who's one of the most important formerly incarcerated persons doing work to create think tanks of formerly incarcerated individuals who are working to understand how to undo a system that has been so unjust to them and to their communities. The fact that more than 85% of prisoners in the state of New York are Black or Latino is absolutely a function of the fact that more than 75% of them in 1992 came from 7 neighborhoods in New York City. I was interested in this because my HIV/AIDS research indicated that New York State prisons have the highest concentration of HIV of any prison system in the United States. And the fact that it drew so many individuals from these 7 neighborhoods meant that we were also looking at neighborhoods that had the highest background infection rates, the highest background seroprevalence rates of HIV. Circulation between the prison and the community has had an enormous amount to do with the way in which HIV, up until very recently, was a heavily urbanized pandemic, another viral pandemic that once again, like COVID-19, took stark advantage of segregated patterns of living and work in the United States. You already know this set of numbers, the degree to which we incarcerate more persons in our prison and jail systems than any other nation on the planet. But it's also the case that what a lot of people don't understand is neatly, I think, captured by the slide that this thing just skipped over, which pointed out that what we're looking at are settings that are congregate, that are often overcrowded, where instead of having the wherewithal to do social distancing, you have just the opposite. So, as is revealed in an article that was published today in the New England Journal of Medicine by Paul Farmer and others, we're looking at a setting that has 5.5 times more likelihood of people being infected with COVID-19 and more than 3 times the likelihood that when infected, people will die of any other congregate set of settings in the United States. We're looking at an area that is breeding disease, not because of the folk who are locked up, not because they are inherently carriers of disease. It is literally because of the conditions and the inability to do everything that is necessary, up to and including making sure that vaccines are available, that makes these settings so dangerous, not just for the folk who are inside, but for all of the folks, staff and visitors alike, who will circulate in and out. I think it's really important to understand, as is pointed out here, that based on some work that was done at the University of Chicago, community jail cycling accounted for 55% of the variants of COVID-19 cases across zip codes in Chicago and 30% of the variants in all of Illinois. Public health speak to say that if you look at the source of COVID-19 in Illinois, but particularly in Chicago, a substantial number of cases are going to be tied to incarcerating individuals in the Cook County Jail. The data suggests that cycling people through Cook County Jail alone is associated with 15.7% of all documented COVID-19 cases in Illinois and 15.9% of all documented cases in Chicago as of April. Trust me when I say efforts to decarcerate in Chicago, I believe, are having some success. But what's really important for this talk is the recognition on the part of all of you in the audience that what we're looking at is a nationwide phenomenon. That means in addition to trying to get our people vaccinated, we have to be on the case of people in power, governors, departments of corrections, to understand that what is putting incarcerated populations at risk is putting all of us at risk, because it doesn't stay confined to the jail or the prison setting. It circulates. And patterns of circulation are the things that are most important to understand how the pandemics and how pandemic illness becomes a major problem for any urban setting where folk are likely to be traveling back and forth, and as a result of their travels, are going to find themselves in settings where they are increasingly at risk. Just trying to get this puppy to move forward. Come on, baby. Yeah, I think that's better. Here's the most important thing of all. 11 million people were admitted to a jail in 2017. Assume that that number goes up and down. In 2020, with a lot of efforts to reduce the number of people who are doing time in jail, you probably had a much smaller number, but what's important isn't the size of the population in the course of a year. It's the fact that at any given moment, in any given week, you're going to have between 500 and 700,000 folks in these kinds of settings. And they're only going to be there for a short period of time. There's going to be a roughly 54% turnover. So having talked to you a lot about how much circulation is at stake here, notice how much jails are particularly problematic. Next slide, please. This is something that just came out last month from Kajipita and colleagues here at the Mailman School of Public Health. They examined the association between county-level jail incarceration rates and county-level cause-specific mortality. This is a point that should carry our efforts to do appropriate levels of pressuring of elected officials about what's happening with decarceration. It's an understanding that it's not just COVID-19 historically. Look at this period from 87 to 2017. What you found was that a 1 per 1,000 within county increase in jail incarceration rates was associated with a 6.5% increase in mortality from infectious diseases. That means that we're not just talking about COVID-19, we're talking about tuberculosis, we're talking about any one of a variety of different problems associated with HIV. Certainly a significant portion of these are STIs. Next slide, please. And the whole notion that we're really talking about a setting where we have, with this pandemic, an opportunity to literally rethink the notion of where incarceration should lie in our nation. Are we clear that these have always been methods of social control? The overrepresentation of people in color in all systems of incarceration, jails or prisons, whether we're talking about the federal or the state system, is one of the ways in which you know that there is a certain bias that wouldn't exist if the numbers of people who were doing time were equal to the same proportions of folk in each of the population groups in the United States. The overrepresentation of Blacks and Latinx folks really indicates that we're dealing with a system of control that, as is pointed out in this slide, often results in a large number of people being arrested who are never going to do time. Reinhardt and Chen noted that 94% of the arrests in Cook County are for nonviolent offenses that are associated with poverty, homelessness, and untreated mental health conditions. We're not talking about a dangerous population that is being preserved so that they can not interfere with the lives of mainstream Americans. We're really talking about something that is increasingly leading to social disadvantage, where the racism that occurs with your permanent membership in second-class citizen status is often associated with carrying a felony conviction. Even jail time, where loss of employment for a week, an inability to attend school for a week can often change somebody's entire life trajectory. And the fact that incarceration follows you around, in the age of Google, a record of having been arrested or doing time is present for everybody to see. Of all the things at a time when unemployment is spiking because of the pandemic, having a record is yet again going to ensure that there will be a substantial number of people in the United States who will suffer economically as well as having suffering as that's associated with health, literally because of a system that is no longer serving our needs. Next slide. And that's assuming that there was ever a point where it did. Next slide, please. New York State prisons have simply been one of the places where you've seen a substantial increase in the number of folk who have been exposed to the virus and who have died. It is clear that, next slide, please, part of what we've been trying to do is get the governor of the state to back away from a notion that only jail, prison staff should be inoculated, but not the people who are on the inside. The courts have already ruled that this is a violation of the 14th Amendment. The Equal Treatment Clause means that equal treatment under the law does not give the governor or the Department of Corrections the right to simply decide who is worthy of a vaccination and who is not, if, as the previous speaker indicated, it is going to be one of the most important factors in determining whether or not we ever come down from the horrors that COVID-19 has inflicted on all of us. Next, please. The geography of segregation in the United States is the geography of early months of COVID-19 hospitalization and mortality. From heavily impacted poor communities of color to the residents of state jails and prisons, the most important and enduring reservoir of COVID-19 infections are these historically redlined neighborhoods and the jails and prisons, which are so much a part of the circulating patterns that have kept this virus alive. Next slide. Mass incarceration, many of you know, you're in a conference like this, so I don't need to tell you that the 13th Amendment basically gave an end to slavery, but it created a backdoor that allowed jails and prisons in the South to have routine access to formerly enslaved populations. And we are living now with the legacy of this notion that somehow or other, in order to keep society safe, those who have been convicted of wrongdoing have to be kept apart. I think COVID-19, I've tried to suggest throughout my comments, is having its moment. We have to question the logic behind that reasoning. And if we're going to question it, next slide. Part of what I think we have to understand comes from these recommendations. From the data I've cited, our findings reinforce arguments that efforts to shift criminal justice administration away from arrest and incarceration may be vital for protecting the public's health during the pandemic and reducing vulnerability to future epidemics. Our findings suggest important points of intervention, including disinvestment from carceral systems and investment in social and public health services such as community-based treatment of substance abuse disorders. In New York City, we're seeing a spike in levels of crime, 47% increase in murders, an almost 99% increase in shootings. There's a lot of political flap going on about whether or not this isn't a moment to rethink the notions about defunding the police, that people are saying with all this crime, we have more and more need for the police than ever before. But what's the logic of that? What is it that the police do? They don't basically deal with homelessness. They do not deal with mental illness. They don't deal with all the problems that are associated with poverty, and they do not deal with the high rates of unemployment, which often drive what we would consider to be criminal acts. What the police do is throw people in jail. Do you see the catch-22? If that's basically how we're going to deal with social problems, put them in carceral settings that will serve as a petri dish from which variants to COVID-19 can begin to develop and fester and provide yet another route of infection for not just the folk who are inside, but everybody who is in a community that is going to have this kind of circulation, it becomes really clear we're at a dead end. Those of you who are interested in helping with assuring that when people return home, they have some place to go, I think we're also invested in the notion that we have another duty. And that duty is to really see how much and to what degree our efforts to promote decarcerization, our efforts to create abolition have to be heightened. What's at stake is not just the health of the folk we serve on the inside. What's at stake is the health of all of us in the United States. If you are able to assist the average American to see that point, to understand that there have to be ways in which we rethink everything from arrest to hearings, to jail time, to prison time, everything that we do to rethink our notions about the best way to handle many of our society's problems will ultimately result not only in a more humane and more ethical society, will also be preserved, I hope, from what is probably going to be an endemic cycle with COVID-19 coming back, just as the flu does, to continue to haunt American society. Some of the answers to the problem are not in the vaccines. They're in the kinds of things that we are concerned with in this conference. They're concerned with the people whose lives are so much at the center of what we do. And I think it literally is upon us to figure out what are we going to do next to help preserve the United States from itself. In the words of the old Black preachers of the 1960s, if not us, who? And if not now, when? Let me stop there. I hope there are time for questions. Thank you.
Thank you so much, Dr. Fullilove and Dr. Shrantz. It was terrific. I have two questions, one for Dr. Fullilove and one for Dr. Shrantz, and then we'll go back to Rashonda. So this one is for you, Dr. Shrantz. Someone was asking, theoretically, If all three current vaccines, so Moderna, Pfizer, and J&J, are available at the same site, is there one that would be a preference for a person living with HIV?
Thanks for the question. So I would say at this time there isn't a preference for somebody living with HIV regarding the vaccines. All of them were tested on people who were living with HIV in the trials. So if you have a responsive disease to antiretroviral therapy, you will respond to these vaccines equally. So I think the message is to get the vaccine you can get as soon as possible. The sooner we can get people vaccinated, the more likely we are to stop variants from evolving, and the more likely we are to return to some normalcy as quick as possible. So I would not be holding out for a certain vaccine at this time. And there are other vaccines that are on the way as well, the Novovax Vaccine. And so as all these come available, they're all safe and effective, and so we should be using them as we can.
Thank you so much. Dr. Fullilove, we have a question for you. Now, this is a big question, but I'll ask you for a rapid idea. So we know, as you talked about, that one of the biggest predictors of health outcomes is zip code. And you talk about geography being the most important characteristic of COVID-19 in the US. You talked about redlining and the systemic issues related to segregation, housing, health disparities, and how this impacts the criminal justice and public health systems. So we have researchers and students and activists out there today. What is the first step that you would tell them to understand and break down these systems? So it's a huge undertaking, but what would you say is the first thing we should all do?
I believe that what we have to do is combat the stigma that's associated with being incarcerated. Our entertainment, how much of our television, how much of our film is really basically about crime and punishment. As a nation, we are so against anything that appears to be coddling criminals that we're actually making it impossible for governments to make informed decisions about what to do, especially when it comes to vaccinating people who are on the inside. I would really want folks to devote as much time as necessary producing the kind of data, writing the kinds of op-eds, appearing on television, and doing their best to tell the general public it's in your best interest to make sure that public health dictate what we do next. And if the recommendation is, let's deal with incarcerated populations as a way of preserving all of our health, let's see if we can't come up with the kinds of arguments that will get people behind that position and will encourage sometimes semi-cowardly governors and elected officials to do what is the right thing. Everybody's afraid that if you're giving a vaccine to somebody who committed a crime before a person who is the victim of a crime gets a vaccine, that some terrible, evil, ethical wrong has been committed. I think that's the wrong framework. The framework, and we in public health and folk who got research backgrounds can do this. What we have to do is reshape perspective. We have to reshape how people are looking at this pandemic so that they'll see that when we make a decision that is in the best interest of all of us, especially from the standpoint of pandemic control, that it's not going to be subject to what they saw last night in their favorite crime and punishment TV show.
Thank you so much. That was a great segue to talking about how when we uplift one person, we uplift all of us together. And when we started out today's conference, Rashonda framed it about rebuilding, rediscovering, and reimagining. And both of you set us on that pathway this morning, and we are so grateful for your excellent talks. Thank you for being here this morning, and I turn the virtual floor back over to Rashonda.
All right, everybody. Hey again. So first of all, can we just take a deep breath? Just inhale and exhale it back out, because that was amazing. Thank you so much, Dr. Fullilove and Dr. Shrantz and Naomi, for a wonderful presentation. I learned so much. I'm still processing what I just heard, and I'm so grateful that all of you were with us today, as I'm sure our attendees are as well. So that was a great way to start the day out. And we're just going to keep building. We're going to keep going along with our day. So throughout today's conference, you are going to have the option to attend 3 different breakout sessions. You will have the option to choose whichever you like. And if you have questions throughout the day, you can place them in our Q&A feature on this platform. And if you are in an actual breakout room, you can place them in the chat feature, and then a member of our team will make sure that we answer you, and you'll be able to recognize them by their Zoom background. The sessions that we are getting ready to go into are Navigating Freedom and Recovery in Post-Pandemic America with Ken Osborne. We're also going to go, we have a breakout session entitled Bridging the Gap, the Impact of Community Health Work on Returning Citizens with our friends at Illinois Public Health Association. And then we also have Anti-Racism, because being not racist isn't enough, and that will be done by Thresholds. So we recommend moving fairly quickly into the breakout sessions, as we have a lot of information to cover in 1 hour. We do realize that we are a little over scheduled, but not to worry, you will still get your full hour, and we will make the accommodations in the schedule accordingly. Again, these rooms can be accessed right here on the platform by clicking the tab at the top of your webpage entitled Breakout Rooms. You're also going to notice that there's a description for the room so that you can see what the topics will be about. Also, please note that upon entering a breakout room, you will be admitted into a waiting room. Our team will move quickly to help you get into the room, but please note that there will only be room for 75 people in each room. So if you do find that your room is filled, we ask that you will go to the next one. If the room is filled, our team will make sure that we let you know in the chat feature. PHIMC staff will be taking photos throughout the day. So if you do not wish for your photo to be captured in the breakout rooms, just make sure that you put an asterisk next to your name so that we'll know not to capture you. And then if you hear anything today, this is super important, everyone. If you hear anything today that you find to be profound, insightful, or new, we ask that you share it on social media, because sharing is caring, and you can use the hashtag Illinois Reentry. Our communications team will be sure to retweet, regram, or share your posts so that we can get other people in this conversation who may not have been able to join us today. And then immediately following the morning session, we will have a lunch break. We're going to cut the lunch break just a little bit short to about 50 minutes. And then you will have that time to regroup, grab something to eat before we come back for the second part of the day, which will begin promptly at 1 p.m. If you have any questions throughout the day, again, you can use the Q&A feature, and a member of our team will definitely respond promptly. With that being said, enjoy your morning breakout sessions, and I will see you all soon.